Okay, everybody, it's about 3 minutes past 6 over here in Texas, so I'm going to go ahead and get started. If people start to trickle in, that's perfectly fine. Just wanted to introduce myself. My name is Alex Hughes. I'm the lead nurse practitioner out here at Austin, Texas, at Austin Urology Institute. My lead surgeon is Dr. Kaushik Shah. I've been a urology nurse practitioner for about 6 years now, and I've kind of morphed myself into our BPH expert at the practice. So BPH is something that affects almost every man that lives long enough on this planet. And it's something that's really not talked about. And the topic of our conversation tonight is going to be our new and emerging treatments and really why you should be seen by a urologist and why earlier intervention is so important. Again, this is an educational seminar. This is not something that I'm giving a diagnosis to any of the patients that are on here. So just use it to your own will. But this is prostate issues and what every man needs to know. This is a little bit about myself. Again, I am under direct supervision of Dr. Kaushik Shah. I'm the leading nurse practitioner, so I train all of our other nurse practitioners on how to do the diagnostic workups that I do. I went to Spring Arbor University and Texas Tech was my undergraduate, and I perform all of our procedures in the practice. I do our cystoscopies, I do our transrectal ultrasounds, I do our axonics PNEs, I do drainages, I do stent removals, and I train all of the new nurse practitioners in the practice. We also have satellite clinics. So the hub of our clinic is in Austin, Texas. And then we have satellite clinics in Georgetown, Texas, and then Dripping Springs as well. So we can also do these diagnostic workups, outside of, our hub area. We also have telemedicine capabilities as well. So my goal here is to explain the importance of bladder health and to get men off of BPH medications and into an effective, durable treatment that preserves their long-term health, mainly their bladder health. So what is BPH? Benign prostatic hyperplasia. I say that that's a fancy term for a big prostate. So hyperplasia is an increase in tissue size. So also known as large prostate. It's a progressive condition which the prostate gets bigger and bigger as men get older. While BPH is not prostate cancer, it can greatly affect the quality of life. This metric is very important. Over 40% of men in their 50s and 70% of men in their 60s have some form of BPH. And what BPH is doing is it's putting pressure on the urethra, causing the bladder to work harder. Okay, that's very important to remember. So 70% in their 60s, that goes up to 80 and 90% in their 70s and 80s. And almost everyone that's in their 90s has some form of BPH. So, what are the symptoms? What are we treating? What gets a patient into our clinic? As the prostate enlarges, it presses on the block in the urethra and causes bothering symptoms as frequent need to urgent to urinate in the day or night. So this is urgency. You know what I mean? So like whenever you feel like you have to go, you got to get to the bathroom quicker. Weak or slow urinary stream. So if you have a garden hose, right, then it's just open and free, and you jab your thumb into that garden hose, the thumb is acting like the prostate. So if you jam it hard enough, you have a very weak trickle of a stream. So your urine stream is starting to be affected from the actually enlarged prostate. Since that you cannot empty your bladder, so this is called retention. And this is one of the later stages of BPH. So it's whenever you go to the bathroom and you pee and you're like, go back and sit down and you're like, I don't feel like I got everything out. That's retention. That's the bladder starting to fail. Difficulty in starting your urine. So, right. So if you're standing at the John and you're like, gotta wait there, wait there, wait there. So the prostate is actually causing a closure on that urethra. So that delay in urination is also BPH. And then stop and starting urine, urination. So this is like, when you're at the toilet, you go, ch, ch, ch. That's stop, start urination streams. And those can all be signs of BPH. Men shouldn't be embarrassed to talk about this common problem. I'm proof that there's help available, and that it's important to talk honestly and openly with your doctor. So I think, I say a lot of times to my patients, men are coming to the clinic earlier. I feel like this is a less taboo topic than it was 15 to 20 years ago, and maybe just the advances to medicine and the availability to medicine is becoming larger and larger. So we're seeing earlier intervention, which is extremely important. So I said this in the beginning is protecting bladder health. So this is the new paradigm shift on how we're looking at urology. So it used to be, all right, I'm going to wait till my symptoms are unmanageable and then I'm going to go see the doctor. And what we're starting to see is that bladder health is being extremely affected by that approach. So you can see on these three pictures, you have a healthy bladder, and then as the bladder or as the prostate obstruction worsens, the bladder worsens and then worsens and it becomes more trabeculated. I'm going to show you some pictures about this later. So basically, the bladder is a muscle just like our bicep, right? Our bicep, we want it to get big and strong. That's why we go to the gym. That's why we lift weights. If the bladder is pushing through a prostate obstruction, this is a low pressure organ. So it's supposed to just hold urine and then empty it out. That's all it's supposed to do. So if you have your prostate and it's starting to close and that bladder is now pushing against that obstruction, it's causing a backflow. And what happens is that bladder starts to get big and thick. And when it gets big and thick, it doesn't function as well as it's supposed to. Think of your heart, right? We all know about low fat diets, right? Decreasing cholesterol because we don't want to have a heart attack. The whole reason you have a heart attack is plaque builds up into the artery, and then your heart works against that and then starts to have an infarct. So the bladder pushing against this obstruction is basically making it hypertrophic. And what ends up happening, and I have later slides that look at this, is you have high PVRs, post void residuals. I'll say that term a lot. So, but the higher your PVRs, the worse your bladder is functioning, and then you can't empty it as well. And it sets you up for chronic bladder stones, chronic urinary tract infections. And the number one symptom from having high PVRs is nocturia, so going to the bathroom at night. So, what patients are doing now? This study was taken in about 2021, and it looked at the BPH ICD-10s across America. So, 34% of patients that have come in for BPH are just monitoring the symptoms. They're not doing anything. Maybe they're looking at coffee, tea, soda, which are bladder irritants, but they're just watching. 64% are on medication therapy, and then only 2% move on for a surgical intervention. I'm starting to see that shift as earlier and earlier intervention is coming into play, but that's currently what's going on. It's only 2% are actually having surgical interventions. The problem with the medication first paradigm, right? So that, that's, I don't want to say old school medicine, but it is. It's old school medicine. It's like, hey, let's throw a pill at it. Let's throw a pill at it. One is cost. So, medications cost, your insurance company money. They cost you some money. Inconvenience going to the pharmacy. Now, I know mail order pharmacies are becoming much more popular, which is helping this, but having to go to the pharmacy every 30 days, every 90 days to fill that. And then you run out of medicines. And I'll say a lot of patients are just like, you know what? I don't want to have to make that drive. I'll just keep going without anything. Lack of effectiveness. This is the number one thing that I, as a provider, care about. They don't work that good. And so a lot of times you need something more to open up that prostate that's not just medicines. And I have a slide, and I think my next slide, that'll kind of show you what I mean by that. Side effects. I talk about side effects a lot. So alpha blockers, this is your tamsulosin, Flomax, alfuzosin, uroxetrol. They were written off as benign medicines, and I have a slide that talks about the side effects, so I won't go into a lot of details right now, but they have side effects, and I've seen it as a provider and prescribing these medicines. I've had patients that have been hurt from these medicines. So if we can get you off of medicines and into an effective treatment, that's either an office-based treatment or an OR-based treatment, it works better. So reported compliance rates, so like how many people are actually staying on their medicines, 29% at year one and 13% at 4 years. So people aren't continuing on with the medications, and if that's what we're trying to do, is trying to help save the bladder and and relieve these symptoms, patients aren't even staying on the meds. So we need to do something else. So do meds even work? So this is a beautiful slide that I absolutely love. And then I'm going to say an acronym called IPSS. So that's International Prostate Symptom Score. So this is a scoring sheet that almost all urology practices should know. I kind of say it's the Bible for BPH in terms of monitoring BPH symptoms. And it's a score sheet from 0 to 35. If you've ever been to your urologist, I would imagine if you're complaining of any urinary symptoms, that you've gotten this score sheet. But you can see, so these are the two classes of medicines we prescribe for BPH. It's alpha blockers and 5-alpha reductase inhibitors. And both of them have side effects. But you can see on the far right that the IPSS improvement is at max around 8 points, right? And that's dual therapy. That's you doing, tamsulosin or alfuzosin and finasteride. In both of those medicines, I talked a little bit about the side effects of the alpha blockers, but the 5-alpha reductase are even more severe. So we're doing dual therapy and decreasing these IPSS scores at best, on average around 8 to 10 points. And look at all these side effects. And, I mean, I have a slide that goes over it, but the alpha blockers, you have dizziness, headache, ED, nasal congestion, EJD, which is ejaculatory dysfunction, meaning your ejaculate goes into your bladder instead of out where it's supposed to go. And then the 5-alpha reductase, mental confusion, sexual side effects. There's lots of these things that are going around. And when I start counseling my patients on erectile dysfunction, ejaculatory dysfunction, fatigue, there is actually a syndrome called post finasteride syndrome. They've labeled a syndrome after it. And I've had 25, 30-year-olds that are taking this for hair loss that are coming in saying, I have no interest in sex. My erections are gone. And when I start counseling my patients on these medications, then they're like, please get me off of them. So that kind of into this next slide here. So my approach on these meds. So alpha blockers, these are not the 5-alpha reductase. These are the ones that most of y'all have probably heard of. Tamsulosin, alfuzosin. Silodosin is also one, but the top two heavy hitters are the top ones. Orthostatic hypotension. So whenever you get up to stand up, so you get that woozy feeling, this can worsen that. It can worsen heart failure, retrograde ejaculation. So a lot of my younger patients, right? I'm going to say younger a lot here, and let's call it 65 and less. You may not have a really bad blood pressure issue. Your blood pressure may be perfectly fine. As we get older, our blood pressure and other things become more labile, and your body does not recover as well. So orthostatic hypotension gets worse. So my example I have is I had a 76-year-old male patient come into me, brand new to the clinic, had never been on any of these meds. I was, under the impression that, these are extremely safe meds to give, et cetera. And most of the time they are. And he had an IPSS score, remember, International Prostate Symptom Score, of around a 17, which is moderate symptoms. So I did the right thing as a provider, gave him a trial of medicines for 30 days. And the second day that he had been on the meds, I got an ER phone call that my patient had gotten up in the middle of the night, which he typically does because of his urinary symptoms and his BPH. And whenever he got up and he was at the bathroom, he passed out and hit his head on the toilet, 17 staples across his head. Now, thank God he was okay. Thank God he wasn't on blood thinners. But these things can happen with these meds. And these are written off as lifetime medications. And we're trying to change the shift of like, okay, I'm just getting older. I'm going to urinate more. I'm just getting older. I got to deal with these things. I'm getting older. Add another pill to my, other 10 pills. So we're all about de-prescribing. That's the whole point. 5-alpha reductase. Dr. Shaw, really started me in this practice and really scared me about finasteride, and that's the 5-alpha reductase. There's other ones out there, but the side effects: erectile dysfunction, decreased libido, ejaculatory disorders, cognitive decline, mood swings, depression. You start talking about these things, and then think about what happens as we get older. Erections get worse. We have cognitive decline. We have decreased libido. why add a medicine that's going to increase all of these side effects? So if I have a patient that's on dual therapy, that's kind of like the package deal with pharmacy in terms of BPH, my first thing to do is get them off of finasteride, get them off of that medicine because of all the gnarly side effects. The other thing scary about finasteride is what it does is it actually shrinks the prostate gland. So what this doesn't do is shrink prostate cancer. So whenever you have a prostatic lesion and we're monitoring your PSA to make sure that it's not, getting worse, what a lot of practitioners don't know is you actually have to double that PSA. So my real life examples, I had a patient that was on finasteride and his PSA was 3, and he needed a clearance from us. He was actually at a testosterone clinic. And we get a lot of patients that come over to us that need a PSA clearance. And when I told him, hey, your PSA is not really 3, it's actually 6. And he actually had a prostatic lesion that was there, and we were dumping or we weren't, but somebody was dumping testosterone on top of this. We ended up getting him treated and he was fine. But those are things that a lot of practitioners don't know. And my other examples, I'm sure y'all have heard of Hims and Hers and these online pharmacies. They will give you finasteride for hair loss. And I'm seeing tons and tons of patients that are 20 to young 30s that are having new set of ED, new set of fatigue, new set of low libido from these medications. So if we can get patients off of them or never start them in the first place, I feel like we're doing a service to these guys. So how do I work up patients? So this is like my tool belt. So as a plumber, I got a tool belt. So IPSS, I've already talked to y'all about that. That's the International Prostate Symptom Score. PVR, this is a post-void residual. A bladder scan is kind of the layman's terms. And this is checking how well your bladder is emptying. A urinalysis, so if you're coming into the urology practice and, you're first seeing us and you have a nocturia complaint. So nocturia means nighttime urination. You're going to get all of 3 of these things. You're going to get an IPSS score. You're going to get a PVR. So you'll go leave a urine sample. We'll tell you to empty out your bladder, and then we'll run that urine sample. And as you're waiting for me, we're going to do a bladder scan to see how well your bladder is emptying. The urinalysis is to see if you have a urinary tract infection, if there's other things kind of going on, because a urinary tract infection in a male patient is very odd. And most of the time that comes from prostate involvement. Eurocuff and Proud P. So my example that I tell my patients out here in Austin when we had that giant freeze, I think it was 2021. I've kind of blanked it out of my memory. But we had a pipe burst out at my house here, and we called a plumber. And the first thing he did is come out to the outside bib and put a pressure gauge on our outside bib. This is our pressure gauge for your urination status. So what it's checking is mils per second, how hard your flow is. And it's also checking how long it takes you to urinate. So that's a Eurocuff. Eurocuff is an in-office urodynamics, you could say, where we're actually, setting you up and we're getting a score. But one of the coolest thing out there is this Proud P. This is an app that you actually use audio to get a urine flow measurement. So it gives you a urine flow measurement. It gives you a volume measurement. And it's on your phone. So you actually put it above your toilet. You hit start, you pee into that toilet, and then you hit stop, and it'll give you an analysis. And it's extremely accurate. I've done, I have it on my phone myself because I like to show my patients it. But I've also done the test myself. I've done myself compared to the Eurocuff. And it's extremely accurate. So what I love about the Proud P is it puts the data on the patient. And out here in Austin, we're surrounded by engineers and a lot of patients that love data. So what I love to see, and I get all of this data in here. So like if you actually utilize the app and pick Dr. Shaw as your provider, I get all your data, and I can see the urine flow measurements pre and post operatively. And I'll tell my patients, this is not just someone that's going to be having surgery. This is someone that's trying medicines or, trying dietary changes, and you want to see what's affecting your urine flow. This is a great app to utilize. I have a whole section on it later, and I'll kind of show you what that is. Some advanced testing that we do is cystoscopy. I compare it to colonoscopy, right? So my dad's a GI doctor, so he was doing colonoscopies all the time. I do cystoscopy, so a camera that looks at the bladder. We talked about bladder health earlier, and I'm going to show you some slides on some severely trabeculated bladders, and you'll see why it's so impactful to get this scan done. Transrectal ultrasound, it's a wand about the size of the highlighter. It's up the backside and it takes a 3D view of your prostate. And then I actually will gear my treatment based on my cystoscopy findings, my transrectal ultrasound findings, my Proud P findings, my UA, my bladder scan, and my IPSS. So that's how I do my workup for BPH. It's not just you coming in and saying, hey, you need this surgery. Hey, you should do this. I use all the data and we come up with a plan together. So an IPSS score, I've said this a lot, and I use it a ton. So like, and I built our BPH care plan pathway at our practice. So every male patient that comes through my door is going to get an IPSS score. I don't care if they're coming in for kidney stones. I don't care if they're coming in for kidney cancer. I don't care if they're coming in for ED. If you're 50 or above, you're going to get this score. So it helps determine the severity of the symptoms. Basically, the categories are urgency, frequency, incomplete intimacy, intermittency, weak stream, straining, and nighttime urination. And it's a score from 0 to 35. 0 to 7 basically means no issues. 8 to 19, you have moderate symptoms. 20 to 35, it's severe. And then it has a quality of life score as well. How much is this affecting you? Because I will have patients that'll come in and they'll score an 8 and they're absolutely miserable. And the complete opposite will happen. I'll have someone that'll score a 25 and they'll be like, I'm fine with it. Now, I think I should encourage a workup for those kinds of patients, but this is our urology BPH Bible. This is our starting point. This is how I start to talk to patients about how severe, their symptoms are. Bladder scan, so a PVR machine. It's a very quick test, 10 to 15 seconds. We put a little ultrasound jelly on your lower abdomen and we're scanning to see how much urine you have left over. Normal is 100 cc's or less. So like if you go and pee, you're supposed to have 100 cc's and less. If it's over 100, then a mild concern. Over 200, abnormal, consider BPH. Neurogenic bladder, the bladder is stopping to work. Retention, 300 to 400, interventions needed. This is where I start talking about using a catheter to empty your bladder until we can actually remove the obstruction. If it's 500, 600, that's me placing a catheter and, until we can actually get that workup. So with bladder dysfunction, and you're seeing these, so usually the bladder volume for a normal adult male, what I say is if I go to the movies and I sit down and I have like a 32-ounce Coke, which I shouldn't because it's a bladder irritant, but say I do. And I sit down and I like kind of had to pee at the very beginning. And towards the end of the movie, I am like doubled over and in pain that I have to pee so bad. That's at about 450 to 500 cc. So that is max capacity of your bladder. So if I see a patient and I put that bladder ultrasound on them and they have 500 cc's left over in their bladder and they're not hurting, that's a big problem. And it's a big problem for a big bladder. And so what has happened is that bladder has been pushing through that prostate obstruction for so long, it has become extremely big, and then now it's rigid, and now it's not functioning appropriately. That's late stage BPH. And what my patients will always ask me, like, what if I just do nothing? If you do nothing, what ends up happening is the bladder fails. Okay, so worst case scenario is the urine goes up into the kidneys and kills the kidneys. It's called hydronephrosis. So that's worst case scenario. Best case scenario with a beat up bladder is you're putting a catheter inside your penis for you to urinate, 4 to 6 times a day. That's what happens with end stage BPH. And I will tell you, no guy wants to do that. Cystoscopy, it's a procedure that I do at our clinic all the time. Tuesdays are my procedure days. I think I probably did 5 or 6 of them today. Basically what I'm assessing is the bladder health and BPH diagnosis. So I'm looking at the obstruction of the prostate and then rule out any other bladder conditions. So, lots of things can mimic BPH, and sometimes I'll do a scope and their prostate's completely open. And this is more of a bladder problem versus a prostate problem. Stricture disease. So the urethra can narrow down and it can mimic BPH. So a lot of times patients are like, why do you need to go do this? And I have an analogy on my on one of my other slides, but it's like I talk about a mechanic analogy. And I'm like, if you take your car and there's a rustling around in the engine block and you're wondering, hey, what's going on in my engine? And the mechanic comes up to you, he's like, man, I've seen this 100 times. Just take this new synthetic oil and get out of my hair. That's me just trying meds. I don't know if this is gonna work. That's me just saying, let's just hope and cross our fingers. What you want your mechanic to do is get in that engine block and see if it's actually, an actual problem or a problem that it can fix. This is my way of getting into the organ system and looking because things can mimic BPH. You could have a median lobe, which is where your prostate grows into your bladder and it kind of acts like a flapper valve over the bladder outlet. And then the stricture disease, other things could be kind of going on. Transrectal ultrasound, this is the actual ultrasound machine in our clinic. The wand, again, is about the size of the highlighter. This says 10 minutes. I tell you, my prostate ultrasounds are done in about a minute and 15. So it is super quick, but it is one of the most valuable tools because we need the exact size of the prostate because later on when I start talking about treatments, this is not one, treatment fits all. It's a very tailored approach for our patients. Let me see if I missed anything here. No. Okay, Proud P. So this is the app that I was talking about. There is a QR code on your screen. If you want to try the app out, you can scan the QR code and you get a 10% discount. This is not covered under insurance, but it's super cheap and gives you lots and lots of data. I would say anyone on this webinar that is on the fence about, hey, do I need help or not? Get in there and scan this QR code and start looking at your urine streams. You will be surprised at how much your urine stream is actually affected. And maybe you'll be shocked to see that you have a urine stream that's, 24, 26 mils per second and have zero problems. But it's a really, really good tool. I absolutely love it for our patients. So again, I have satellite clinics, so it's hard to get patients sometimes in to do a Euro cuff. I will say that the Euro cuff has some limited parts about it. So anatomy, stage fright, if you get what I mean. Nobody loves to pee while a nurse is just staring over your shoulder. There's electrodes all over it. So this is a very good way of getting a urine flow measurement you can share the data with me. So if you choose Dr. Kaushik Shah, the data goes to our portal. So if you're a patient of ours, then obviously I can view this and you can talk to me through the portal. If you're from somebody from the outside, get in there and you can do your own data sets. And then you can potentially become a patient of ours and we can talk about it. But it is an FDA Class 2 Euroflow device available on smartphones. This is really how it's set up. You put the phone right by the toilet, you pee and you hit start, you pee into the toilet, you make sure you get into the middle of the bowl, you hit stop when you're done, and it shoots you an analysis. You can do an IPSS score on this as well, and all of this is shared with your provider. So how do we tackle BPH? All right, I've talked to you about the workup. I've talked to you about why you need to do these things. So what do we do? First thing, if you have never tried meds, now as a urology specialist, most of the time, my patients have already tried some medications. So if they've never tried anything, we all are at the bay of insurance gods. We may have to try a medication trial. We try 30 days of alfuzosin, which is your Roxetrol, or 30 days of tamsulosin, which is Flomax. And then we bring you back. So if you have an IPSS score and it's like a 20 and I put you on an alpha blocker and you come back and it's at 15, I know that BPH is your diagnosis and I start putting you down the actual pathway of the Proud P, Eurocuff, cystoscopy, and transrectal ultrasound. Now, once I do your workup, UroLift is a very, very good office procedure for smaller prostate glands. So it's non-invasive office procedure for smaller glands. Aquablation therapy is for our larger glands, and it is an OR procedure. TURP is still gold standard. So y'all talk about Roto-Rooter. If you've ever heard of Roto-Rooter in passing, that's the TURP. It was invented in the 1920s. Can't believe that. So we're still using 100-year-old technology today. But UroLift and Aquablation are our pride and joy. We've had a ton of success with it, and I'll walk you through each one of them. I have 2 videos to show y'all in the next. A UroLift is first, and then the aquablation.
The UroLift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructed prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
So that was the UroLift. The visual was fantastic. The beautiful thing about this, smaller prostate glands, right? So I kind of joke that if you're using a staple and then you have a single piece of paper back here and you staple a single piece of paper, it'll probably stay there for long. The more pieces of paper you put on there, the harder it is for that staple to hold. So the bigger the prostate gland, the least effective the UroLift system is. So for 50 grams and less, UroLift is on the table for our patients. And for our bigger prostate glands, and this is 30 to, and basically there's no max, we have aquablation therapy.
The Hydros robotic system is the next generation AI-powered robotic platform that delivers aquablation therapy for benign prostatic hyperplasia. This clinically proven therapy uses real-time ultrasound guidance combined with cystoscopy to provide surgeons with a full detailed view of the anatomy. Developed from a library of real-world aquablation therapy procedures, First Assist AI identifies critical anatomy on ultrasound to aid the surgeon in designing a patient-specific treatment plan. Through robotic control, the heat-free water jet precisely follows the treatment plan. During every procedure, prostate tissue is accurately removed in an efficient and predictable timeframe. The streamlined workflow begins with the insertion of an ultrasound probe, providing the surgeon with a full view of the prostate. The single-use handpiece with integrated cystoscopy allows the surgeon to visualize the anatomy as it is inserted, positioned into the bladder, and docked to the articulating arm. Once the entire prostate is visualized, the surgeon initiates treatment planning. Treatment planning begins by identifying critical anatomy using First Assist AI to develop a plan specific to each patient. Adjustments to the plan can be made to the resection angles and depths under real-time ultrasound. The Verumontanum protection zone is created to help protect sexual function. Robotic-assisted resection removes the desired tissue and avoids the verumontanum by using a bilateral cut to help preserve ejaculatory function. The surgeon maintains control of the resection throughout the entire procedure. Once water jet resection is complete, The surgeon performs focal bladder neck cautery using a resectoscope to cauterize exposed blood vessels at the bladder neck. The Hydros robotic system is the next generation AI-powered robotic platform for aquablation therapy, a clinically proven procedure that provides significant durable symptom relief while preserving sexual function and continence across prostates of all shapes and sizes.
So those are our two big treatments at our practice. We are very, very, very good at them. I have a very good surgeon that I've had a giant success with it. And the reason why I love these therapies are because my patients are doing well with them. So the biggest things is what I compare this to is TURP, right? The rotor-rooter. But the other bigger resection procedures like pull-up and, green light laser, you will have sexual dysfunction, you will have erectile dysfunction, or you have a higher risk of those things. If you're doing a hole up, you will not have any more ejaculate, so the stuff that you shoot out. So aquablation therapy and urolift really came into the game when they started to realize guys care about their erections, the guys care about their ejaculate. And stress urinary incontinence. You do not have a high risk of stress urinary incontinence. I've done so many aquas. I have yet to have anyone that has had any kind of stress urinary incontinence after it. Um, so these are our wall boards. So like in the middle of the page here, you can see these two graphics. These are wall boards that we utilize in the clinic. So I will actually draw this out. I sit down and I talk with my patients. I show them what we're looking at. If we have a median lobe that we'll be kind of tackling with an aquablation therapy, I draw that on the wall board. I draw the trabeculations in the bladder. I draw the PVRs. I really want my patient to understand what's going on inside of them and why they would choose the right therapy for them. So these were my analogies. I talked a little bit about my mechanic analogy, clogged toilet. So retention, right? I mentioned this on the PVR, the bladder scans. So what happens whenever you flush a clogged toilet and you don't deal with the clog? Where does the water go? Outside the bowl. This is where I'm telling my patients the urine goes into the ureters and into the kidneys. And this is why kidney dysfunction starts to happen. The rings of the tree, I talk about bladder health, trabeculation. This is when I'm doing a cystoscopy on a patient and I'm showing the patient at the bedside what their bladder looks like. My next slide will show you some examples of some cystoscopies and you will see why it's so important for the patient to see that. So I talk about if you cut the tree in half and how old that tree is. I would say how severely trabeculated the bladder is how long you've been dealing with BPH and how close you are to bladder failure. Cleanup batter. I talk about at the end of my appointment, I've done my whole education. I've talked to the patient till I'm blue in the face. I'm like, it makes no difference on my wallet or anything like that, which option you choose. The only benefit I have is to see my patients do well. And the satisfaction that I get when I see an IPSS score from a 30 down to a 7 or a PVR from 300 down to negligible to 50s, to decreasing these urinary tract infections, to, hey, allowing your wife to sleep through the night. I will tell you, that is one of the biggest reasons patients come in, is it's with their wife and they're like, I can't sleep anymore because Jim is getting up 5 or 6 times. Sorry if your name's Jim on there. But that's where it's really become. And then honestly, it's a selfish reason. So me and the other providers at Austin Urology Institute cover our patient's call. So, right, if our patient from our clinic is calling after hour service because, hey, I'm still bleeding or I'm having dysuria, I'm having X, Y, and Z, we have to field those calls. After we really started doing aquablation therapy, those call volumes almost went down to zero. So our patients are doing extremely well and they're happy with the procedures. We have to undo generations of fear. Today's BPH treatment is not your grandfather's. This is one of my biggest pet peeves when I have a patient come into my office and they're like, "Nuh-uh, you ain't touching my prostate. My buddy Mark had that done and his fingers fell off or whatever it is." And I'm like, "Okay, we've cooked prostates, we've heated them up, we've put clips in them, we've steamed them, we've water vaped them, we've green lighted them, we've hole up them. what had he done? Because, prostatectomy, I'll have patients that'll be like thinking of prostatectomy for prostate cancer is what their friends had done. And there is a simple prostatectomy for BPH. We don't practice that because of all the side effects. But again, there's 15 things that can be done to the prostate, and you just need to make sure you're having the right workup and tailor it to yourself. So these are my cystoscopies. So these are pictures, and I will say my far left one is one of the ones that I remember the most. This was a cardiologist that had been on dual therapy. So remember, that's finasteride, or sorry, 5-alpha reductase and an alpha blocker for 20 years. His urologist had retired, so he needed a new urologist. He came in to see me. I put the bladder scan on him, and he had a 300 PVR. PVR, post void residual, remember what that means. So the bladder was dysfunction. And because he was just coming in for med renewal. That's all he needed. His urologist retired. He's like, I need my meds. And I talked to him about, have you ever done a cystoscopy? Have you ever done a transrectal ultrasound? And he had never done one in 20 years. So, you can imagine his eyes whenever I scope him and I show how severely trabeculated your bladder is. I'm like, this is why your medications aren't helping you anymore. He thought there was nothing else to be done. So that's a grade 3 trabeculation. That middle one's a grade 2 trabeculation. And on the far right, you can see that giant ball in the bladder. That's a median lobe. No matter how many meds you take, nothing is going to help that. The only way that's found is on MRI or a cystoscopy. So get in there and get scoped. If there's nothing wrong with you, then we're happy. Let's go on about our lives. So this is my care plan pathway. I talked a little bit about it, so I won't belabor it a lot. But BPH consult, perform an IPSS, PVR, UA, DRE, which is a digital rectal exam. If they're not on meds, we'll give them a medication trial for a month. If they're on medications, I want to wean them off those medicines and see if their BPH symptoms worsen. So then we can confirm a BPH diagnosis. And then once we have that step, if their IPSS doesn't change and they either were not on the right medication regimen, maybe the symptom tree that they were tackling was not the correct one. If no change, we just keep surveilling them. But if their IPSS decreases from the meds, then I've confirmed BPH. If their IPSS increases, if I take them off the meds, then I've confirmed BPH. So then I move them on to cystoscopy, transrectal ultrasound, Proud P, and Urocuff. And then we discuss the surgical options. 30 grams or less, that's a UroLift. 30 to 50, UroLift or Aqua. 50 or above, it's Aquablation only. So this is my data. So I went into, me and my surgeon's data, I should say. But I went and dug through all of our 2024 numbers. 72% average decrease in IPSS score from a surgical intervention. So this is either a UroLift or Aquablation. And my favorite one is 87% of these patients remained off of their medications. Huge decrease. I mean, you're seeing this from, IPSS scores of 30s all the way down to the 5s and 4s. So my recommendations, talk to your doctor early. Don't wait for symptoms to worsen. This is my, I've said pet peeve like 8 times in this, but this is another one. It's like, I'm just getting older. I'm just dealing with this. Of course, I'm waking up in the middle of the night. I'm getting older. Of course I'm peeing, 10 times. Yeah. Yes, you are getting older, but that doesn't mean that there's not interventions to help you. If you're on medications, review the side effects regularly. Talk to your prescribing doctors. Or you know what? Come in and see me. I will talk to you about the side effects of meds. Fatigue, dizziness, sexual changes. If you're having any of those things and you're on these medications, maybe you need to be off those meds and get into some other treatment. Know that there are modern, minimally invasive procedures that preserve erections, ejaculation, and continence. That's where BPH is going, is going to, because let's get honest, we're having sex later in life, we're living longer. So, why not preserve those things? You don't have to live with it. There's safe, effective treatments that are covered under insurance. That's one thing that I haven't hit on, but all of this stuff is covered under your insurance. We pay big premiums. Utilize your insurance so that you can actually get into these treatments, and they can significantly improve your quality of life. So I hope y'all enjoyed that. I went longer than I expected. I get a little heated and a little passionate when I start talking about this stuff. So I know I went about 15 minutes over my allotted time. I was planning to be done at about 6:30, 6:35. Uh, so again, my name is Alex Hughes. I am the lead nurse practitioner out here in Austin. This is all about BPH, and I have some time for questions if you would like. I think y'all can ask them in the chat or the Q&A. So if y'all have any questions, please put them in there. And if not, I'll send out a kind of a recap video or even this video if y'all have any kind of questions. All right, got one question. How often should you see your urologist? So it's a very good question. Depending on what you're doing, if you are on BPH medications or erectile dysfunction medications or have high PSA, you should at least see them yearly. We have a strict policy that we do not do auto renewals of our medicines, exactly for this reason, because your body is changing. Your body will overtake your BPH medications. So if you're not seeing your urologist yearly and you're on tamsulosin or alfuzosin and finasteride, I highly encourage you get in with them. How often should you have these tests? Depends on which test you're actually asking about. Now, PSA, your prostate specific antigen, this is your prostate cancer screener, should be done yearly after 50. And if you're on these medications, then I would say you need to at least be evaluated by an IPSS score and a PVR every year. This is another question. Do I have to start on medication after the first visit? Why not start the workup right away? Great question, and I love the way you're thinking. Now, again, I will say I said it earlier on into the actually in the webinar. We are all at bay at insurance, so sometimes insurance requires you to do 30 days or 90 days of a failed medication before they'll actually start with a surgical intervention. Now, in terms of just looking at your bladder health, I agree. Getting a cystoscopy, I wish was as common as colonoscopy, right? So colonoscopy, we just, when you're 50, you have to get a colonoscopy, or you should get a colonoscopy. But it's because colon cancer is so rampant. Bladder cancer is not nearly as significant as colon cancer, so it's not mandated by insurance companies. But if you wanted to check your bladder health, the first thing I would highly encourage is doing that Proud P app. It's $20, I think, a month, give or take, and it really gives you a clear answer on if you're having some urine flow obstruction. Yeah, let me go back to the code. UroLift is done in the office and in the hospital. It really depends on the anatomy. So UroLift also has a clip that is for the median lobe. So if I do your cystoscopy and I see a median lobe, whenever the doctor is in there actually doing the UroLift, he has to torque a bit and it's a little uncomfortable. So if you have a median lobe, or like say you didn't handle the cystoscopy very well, then we can do it in the surgical suite. But it was manufactured to be done in the office. So we put lidocaine into the prostate, we numb it up, we give you some laughing gas, and we actually clip the prostates in the office. So this question was how often or how long do you have to wear the tube? They're talking about the catheter and how long do you have to stay in the hospital? Good questions. So UroLift, 90% of our patients do not have a catheter. When you do aquablation therapy, because you have a orifice that we've just treated, so that area can slough off, so scabs and some blood can come out. You have a catheter for 1 day. This is how long do you stay in the hospital? 95% of our patients were doing same day discharge. So you're not staying overnight in the hospital at all for aquablation most of the time. I'll make sure that's available. So we'll have it up on our YouTube as well. So I know like once we kind of get it to marketing and we get it fine tuned, they like to edit out my ums and stuff. We'll have it available on YouTube for sure. Any other questions? And if y'all do end up scanning this QR code, make sure that you share it with Dr. Koshik Shaw, especially if you're a patient of mine or a patient of the practice, so we get all your data. And we can walk you through it. And obviously we can, if we end up moving forward with any kind of surgical intervention, we can submit it to insurance. All right, everybody. I don't see any more questions kind of coming through. Again, I really appreciate y'all's time. I know that y'all took your time out of y'all's night to come and listen to me. I really appreciate it. And again, if y'all need to be seen by us, come in. Our phone number is 512-694-8888. You can actually text our number as well too if you're looking for an appointment. If you're a current patient of ours, sign up for your portal, message me. I'm on it far too often. Other than that, y'all have a good night.